I am Dr. Alan Pietrobon. I'm the chair of the Global Affairs Department at Trinity Washington University in Washington, D.C. We're a women's college and a minority-serving institution with a deep commitment to the education of women. And I have the distinct pleasure of introducing our event today. In this panel, we've endeavored to bring together a number of diverse perspectives relating to social policy around inadequate housing, discriminatory laws, and systemic inequities around health for women in Brazil and Peru. And during our discussion today, we'll explore some of the academic research conducted and presented by the Trinity University students, but we'll also highlight the experiences of some women working on the ground in these countries to confront and combat these issues. They'll share with us the successes they've had and the work they still have yet to do. And we're pleased to be supported in this effort by our partners with the Citizens for Global Solutions, the Green Hope Foundation, and the Sisters of Notre Dame de Namur. And to everyone viewing today, we at the end will have plenty of time for questions and answers, so please feel free at any point during the conversation. If something catches your attention, you can use the little Q&A toolbar button to ask a question. Those will be collected and posed to our panelists at the end of the presentations. And it's now my great pleasure to introduce Sister Isabelle Izika. She is the representative at the United Nations for the Sisters of Notre Dame de Namur, and she'll begin with some opening remarks. Sister, over to you.
Thank you very much, Professor Allen. Good morning, distinguished guests, colleagues, partners, and friends. It is an honor to welcome you to Closing the Gap, Housing, Health, and Inequity in Latin America. We have chosen Brazil and Peru as our focus because these are the two Latin American countries where the Sisters of Notre Dame de Namur currently serve the people of God. We gather not only to discuss policy, but also to confront lived realities shaped by structural inequality. Across the region, the circumstances into which a woman is born, her race, income, geography, and access to essential services profoundly shape her opportunities and health. Access to education, safe housing, clean water, health care, child care, and transportation determines whether millions of women in Latin America can live with dignity and security or face persistent vulnerability. Housing is often treated as a technical issue of supply, zoning, and finance. Yet, for women, especially those of low incomes, housing is deeply personal and profoundly gendered. Housing affects safety, physical and mental health, and economic stability. A secure home determines whether a pregnant woman can access prenatal care or children can grow up in safe environments, whether old women can age with dignity. When housing is inadequate, the health consequences are immediate. The house, which should provide protection, too often becomes a place of danger. Today, we will hear three students from Trinity, Washington University, who will share their research on housing and health in Brazil and Peru. Why Brazil and Peru? The Sisters of Notre Dame in Namur have accompanied the people of Brazil and Peru since 1967 and 1967 and 1970, respectively. These global studies and nursing students and their Professor Alan Petrobon have joined Citizen for Global Solution as Global Governance Fellows. They have worked hard to extrapolate the issue women face in Brazil and Peru and are eager to share their findings with us today. In addition to the resources that the Sisters of Notre Dame in Peru and Brazil have shared with us, we have invited two organizations to lend their expertise to this presentation. They are Impulso Gov and Green Hope Foundation. Impulso Gov was founded in 2019 and focuses on health. Green Hope Foundation was founded in 2012 and focuses on environmental well-being. Please welcome our panelists as they share this year's presentation, Closing the Gap, Housing, Health, and Inequity in Latin America. I thank you. I now welcome Margot.
Thank you, Sister Isabel. Good morning, everyone. I am Margot Malumbu, a nursing student at Trinity Washington University. I'm honored to serve as the moderator for today's session. It is my distinct pleasure to introduce our next speaker, Anastasia Tomlinson. Anastasia is a Trinity University student studying politics and policy with a minor in environmental justice at Trinity University, focusing on the intersection between the environment and public health. Anastasia, I now turn the floor over to you.
Thank you, Margot. Good morning. My name is Anastasia Tomlinson. Today, I will be talking about the structural inequities in South America and their impact on women's health, focusing on Brazil. More specifically, I will be mentioning land, housing, and policy failures. These barriers are not isolated challenges. They intersect with gender, class, and state policy to shape women's health outcomes in ways that are predictable, patterned, and unjust. Housing, poverty, and discriminatory laws operate as structural determinants of health. The agenda today is as follows. I will begin covering the physical and mental health impacts of women, as well as reproductive and maternal impacts. Belky will speak about structural barriers, land rights, and housing in Peru, and Samara will introduce community-led solutions in health as justice in practice. We will then hear from our experts today working in the grassroots level in Latin America. Today, we are going to tell the story of two women, one in an urban area named Casilla and one in a rural area named Rosa. They are fictional characters who will help us characterize the issues we are covering in this presentation. While these are not real people, the issues we mention are. We had the privilege of hearing real individuals who shared their stories which inspired the characters. We will start with Casilla. Casilla is a pregnant 34-year-old woman with a husband and two children. She is living in Sao Paulo, Brazil. She migrated from Maraja do Sena 10 years ago, fleeing economic hardship and seeking better opportunities for her two kids, ages 8 and 12. She works as a street vendor selling food, earning an irregular income that barely covers rent for the single room she shares with her husband and children in an informal settlement. Physical health impacts. There are three physical health aspects that impact health, and they are overcrowding, substandard housing, and lack of water and sanitation. Overcrowding is defined as more than two people living in the same bedroom or multiple families living in one residence. Overcrowding and inadequate ventilation in confined spaces increase the risk of transmitting respiratory diseases such as tuberculosis, pneumonia, and influenza by facilitating the spread of airborne pathogens due to high population density and close contact. Proper ventilation is essential for reducing indoor air pollutants. The effects of the global pandemic, COVID-19, highlighted the issue of overcrowding even more. A favela called Complexo de Mar houses around 140,000 people, more than half of which are women. The proportion of fatalities to positive tests were extremely high, with many of them residing in overcrowded housing with poor access to water and sanitation services and incomes being decimated. It has been extremely difficult to halt the spread of the virus. It is estimated that 45% of households in Latin America and the Caribbean lack adequate housing, representing approximately 300 million people, varying by country. Proximity to polluted sites such as industrial facilities, electrical substations, pesticide-treated agricultural land, high-traffic roads, nuclear power plants, and gas stations has a negative impact on physical health. These environments are linked to pregnancy complications, such as congenital disabilities and low birth weight, due to exposure to heavy metals and volatile organic compounds that interfere with fetal development. In addition, women are disproportionately affected by indoor air pollution from wood-burning stoves and cook stoves, particularly in rural communities and developing countries, where they often spend a significant amount of time in cooking areas. In the case of Garcia, she has to juggle maternal care while developing lung disease due to the gas from the stove and mold. Her children developed autoimmune disorders as a result, leading to her having more strenuous tasks in the home. In 2020, only 75% of the population of Latin America and the Caribbean had access to safely managed drinking water, and just 34% had access to safe sanitation systems. In informal settlements, the lack of safe sanitation and drinking water, combined with overcrowding, exposes residents to pathogens that cause diseases such as gastroenteritis, diarrhea, and parasitic infections. Poor hygiene and increased risk of food and water contamination due to shared sanitation facilities further contribute to these health risks. Other studies have made the connection between living environments and health, showing the health risks associated with certain built environment features, such as the lack of potable water or sewage, causing increased incidence of diarrhea or acute respiratory infection among the urban poor. For example, when studying infant deaths and living conditions, research from Sao Paulo shows that babies living in favelas or informal neighborhoods have higher death rates. Chronic housing instability exposes women to prolonged stress that accumulates over time, often referred to as trauma loading. International human rights bodies recognize that insecure housing, forced evictions, overcrowding, and unsafe living conditions are directly linked to anxiety, depression, and long-term psychological distress among women, particularly those living in poverty. Studies examining housing insecurity and mental health show that women experience higher emotional burdens due to caregiving responsibilities, fear of homelessness, and social stigma. The stress of maintaining family stability in precarious housing environments significantly increases the risk of depression and psychosomatic illness. These effects are intensified in informal settlements where access to health services is limited. Housing insecurity functions as a social determinant of mental health. Without stable housing, women face barriers to seeking mental health care, resulting in untreated trauma and intergenerational psychological harm. With reference to Garcia, she experiences stress related to childcare, limited money, and housing instability, which has led her to depression and anxiety. Her mental health is neglected because of the sheer load of labor she is involved in, her lack of access to health care, and her lack of support in the home. The threat of eviction or forced displacement places women at higher risk of gender-based violence, particularly when safe and affordable housing alternatives are unavailable. The UN documents that women may remain in abusive relationships due to fear of homelessness, economic dependency, or lack of legal protection. Displacement and eviction disproportionately affect women-headed households, exacerbating exposure to violence and limiting access to justice and health services. These risks are compounded in rural and marginalized communities. In reference to Cassia never knows what to expect with her partner. Sometimes he's had a better day at work. Other times his stressors manifest in the home. The emotional burden of caregiving for their children, as well as navigating her husband's temperament, adds so much to the stress of not being sure where her family is going to live next month. Although on average 90% of women in Latin America and the Caribbean have at least 4 prenatal visits, large inequalities exist. Women in rural areas have fewer prenatal visits compared to women in urban areas. The main barriers to obtaining skilled birth attendants in Latin America and the Caribbean include the lower availability of medical personnel in rural and low-income areas, long and logistically difficult travel distances to health facilities, the associated costs of seeking care, and perceived low quality or poor treatment available at health centers. In Latin America and the Caribbean today, a child's parents' socioeconomic status still has a significant impact on a child's future. While child mortality has more than halved in recent years, children from low-income homes are 5 times more likely to die before their 5th birthday, the majority of whose deaths could have been prevented. Cassia has only been to the doctor once to check on her pregnancy. She can't afford to go more than that. She tries to eat clean and stay hydrated, but her house has mold. She hears her kids coughing, but there's nothing she can do to stop it. She awaits the birth of a healthy baby. Gender labor markets in Latin America concentrate women in low-wage, informal, and precarious employment. This limits access to health insurance, maternity protections, and stable income, increasing vulnerability to housing insecurity and poor mental health. In addition, gender labor markets in Latin America concentrate women in low-wage, informal, and precarious employment. This limits access to health insurance, maternity protections, and stable income, increasing vulnerability to housing insecurity and poor mental health. Studies suggest that pregnant women from minority ethnicities have unequal access to prenatal care. In Brazil, various studies have noted that Afro-descendant women have less than the recommended number of prenatal care visits, are less likely to receive the recommended prenatal procedures and examinations, and their care is of lower quality. Similar findings have been documented for indigenous women in Guatemala, especially those who do not speak Spanish. Access to gender-based violence responsive services remains a critical challenge for women in transit across Central America. Essential gender-based violence services are often located far from main transit routes, making women on the move travel long distances, sometimes more than a kilometer, to access support, increasing risks of violence and exploitation. Since gender-based violence is often normalized, women may not realize their experiences are forms of gender-based violence. Service providers report that women in human mobility often seek basic care services instead of specialized gender-based violence support because they do not identify themselves as survivors of violence. Additionally, societal stigma and prejudice against migrants further discourage them from seeking help. In Brazil, 1 in 3 women aged 16 or over have experienced some sort of physical or sexual violence perpetrated by an intimate partner or ex-partner in their lifetime, increasing to 43% when accounting for psychological violence. In addition, femicide is a large concern, with 1 woman murdered every 6 hours in Brazil in 2022. Afro-descendant women are the most affected group of femicide, representing 62% of femicide and highlighting the structural levels of misogynoir. Across Latin America, women are not waiting for systems to change. They are building alternative infrastructures of care, protection, and justice. Cassia's story highlights the impact of 3 core issues: land, housing, and policy failures, and the ramifications in Brazil and the broader South America. Thank you so much for your time today.
Thank you, Anastasia, for those insightful remarks. I would now like to introduce our next speaker, Belky Lemus Alvarado. Belky is a 3rd-year Global Affairs and History double major with aspiration to attend law school and advocate for social justice. Belky, the floor is yours.
Good morning. My name is Belky Lemus, Alvarado, and today I will be talking about how structural barriers, particularly around land rights and housing, shape the lives and health outcomes of women in Peru. Peru is a beautifully diverse country stretching along South America's Pacific coast. It encompasses three distinct ecological zones: the arid coastal region where the capital sits, the towering Andes Mountains, and the vast Amazon rainforest, covering nearly 60% of its territory. Home to over 33 million people, Peru's population reflects centuries of indigenous heritage, Spanish colonization, and migration. Approximately 26% identify as indigenous, with Quechua and Aymara being the most widely spoken indigenous languages alongside Spanish. Yet, despite this rich cultural heritage, Peru remains one of Latin America's most unequal countries. While Lima hosts international businesses, modern healthcare facilities, and formal employment sectors, rural and indigenous communities, particularly in the highlands and Amazon areas, face systemic marginalization. These regional divides are not merely geographic, they are deeply gendered. Women in rural Peru experience many disadvantages: limited access to land ownership, restricted legal documentation, concentration in informal labor, and healthcare systems that fail to reach them. Understanding Peru's inequalities requires looking beyond individual hardship to see the structural systems that produce them. Now let's meet Rosa. Rosa is a 41-year-old Quechua woman living in a remote Andean village. She farms a small plot of land with her husband and cares for her 4 children and her elderly mother. Rosa and her husband work land that has been in his family for generations, but they have no formal title. When Rosa's husband suffered a stroke 2 years ago that left him disabled, she tried to take out a loan to cover living expenses. The bank refused due to no land documents in her name. Rosa works from dawn to dusk, farming, cooking, and caring for her family. Last year, she started feeling chest pains and fatigue, but she has no time to rest, no money for treatment, and the nearest hospital is a 3-hour walk down the mountain. Her husband refuses to formalize land ownership, and Rosa fears that her children and her could lose everything if something worse happens to her husband. Rosa's story is not an exception. It is a pattern that runs through the lives of women across rural Peru. And understanding why requires us to look at how differently women's lives unfold depending on where they live. Peru's urban cities like Lima offer women greater access to hospitals, formal employment, and legal institutions. As of February 2024, 39% of seats in Peru's parliament are held by women, and 66% of women of reproductive age have access to family planning. These are real gains, and they show us decades of advocacy and policy work. But even in cities, progress is uneven. Women across Peru, urban and rural alike, spend nearly 23% of their time on unpaid care and domestic work. That is more than double the 10% that men contribute. This is time that cannot be spent working, earning income, or seeking medical care. Women also face higher unemployment rates than men at 5% compared to 4%, and are overwhelmingly concentrated in informal employment, such as street vendors, market sellers, and domestic workers that offer no benefits. For rural women, these same structural barriers are compounded by geography, ethnicity, and isolation. In Loreto, a region where roughly 55% of the population lives in isolated river-edge communities, Indigenous women face severe barriers to healthcare, education, and sanitation, resulting in high rates of infant mortality and barriers and maternal deaths. The consequences of these barriers are visible in Peru's maternal mortality data: 69 deaths per 100,000 live births, above the Latin American average of 45. These deaths are disproportionately concentrated among rural, indigenous, and poor women, the women living furthest from hospitals, furthest from legal protections and furthest from the systems meant to serve them. At the center of this inequality is something that rarely appears in health policy conversations: land. Who owns it, whose name is on the title, and what happens when it isn't documented at all. Peru's 1991 land registry law and agrarian investment law promoted the creation of land markets, yet women's access to those markets remained unequal. Research shows that in rural Peru, women own only just 345 plots of land compared to 1,813 owned by men. And 72% of women's land ownership comes through inheritance rather than purchase, compared to roughly 47% for men. Women are not acquiring land on equal footing. And yet, when women do own land, the outcomes are transformative. Research finds that when female head of households hold individual property titles, their participation in agricultural decision-making increases by 325%. Land ownership generates 30% more participation in the number of agricultural activities in which individuals make decisions. A separate study on informal land ownership in rural Peru found that women owning land increased household food security by 20 percentage points, an effect that holds even without formal titles. Women, the research suggests, use land ownership to directly prioritize family nutrition without needing to negotiate with spouses over household resources. It is also important to note that joint land titles, which might seem like a fair solution, actually reduce women's independence by 39%. Women do not just need access to land, they need land that is legally and individually recognized as theirs. We have seen that women in Peru, whether in the highlands of the Andes or the outskirts of Lima, face layers of inequality. From limited access to healthcare and formal employment to being excluded from owning land they work every day. These barriers shape every aspect of a woman's life. This is not just a Peruvian issue. It is a call to action for policymakers, advocates, and communities to recognize that women's rights to land, housing, and healthcare are not separate demands, they are the same. We must push for policies to put land titles in women's names, expand healthcare access to rural and indigenous communities, and make women's economic contributions visible and protected. Thank you.
Thank you, Belky, for adding on into this important discussion. Up next, we have Samara Husain, a nursing student at Trinity University who is focused on promoting equitable access to healthcare and justice for women. Samara, the floor is yours.
Thank you, Margot. Good morning, everyone, and thank you so much for being here. My name is Samara. I'm a senior nursing student at Trinity Washington University, and today I'll be briefly highlighting how we move from recognizing structural injustice to advancing concrete, community-led solutions that redefine health as justice in practice. All across Latin America, we have seen today how housing instability functions as a structural determinant of health outcomes. Now, it is important to emphasize that these outcomes are predictable. They're patterned along the lines of gender, class, race, and geography. So the question now is no longer whether housing and legal inequality harm women's health. The question now is how do we respond to it? To respond effectively, we need to shift how we define health itself. Health cannot be reduced to just access to clinics or the absence of disease. A justice-based public health framework recognizes that health is inseparable from dignity, safety, housing, legal identity, and power. In other words, health is not only a medical issue. It is a political, economic, and social one. Power relations determine whose lives are protected, whose labor is valued, and whose health needs are prioritized within public systems. When health systems operate independently from housing policy, land governance, climate resilience, and gender-responsive frameworks, they simply cannot reach the women who are pushed to the margins through informal settlement, displacement, or lack of legal documentation. Without integration across these sectors, we risk treating symptoms while leaving the underlying drivers of inequality untouched. So keeping that in mind, let's talk about what does work. justice-based community-embedded models. Research consistently shows that community-embedded models succeed precisely because they meet women where they are regionally, socially, and institutionally, through approaches that integrate health, housing, legal identity, and economic stability alongside clinical care into a single, accessible pathway of support. Evidence from global and regional studies demonstrate that interventions rooted in trusted social networks are significantly more effective at reaching populations excluded from formal institutions. Women are more likely to seek care, disclose gender-based violence, engage in prevention, and maintain continuity of services when these support systems are delivered through actors that they trust. Just to clarify, community leadership does not replace public systems. It makes them reachable. And they do this by acting as intermediaries between women and the state. And they do this, again, by translating rights on papers into services in practice. If you've noticed, the success of these models make this something very clear. They cannot do this work alone. Their impact depends on sustained intersectorial collaboration across health systems, housing authorities, legal frameworks, environmental policies, academic institutions, and funding bodies. So keeping that in mind, there's some evidence that points to three core priorities to address the problems that were outlined by Anna and Belky today. First, we need sustained investment in women-led community-based organizations. These organizations are often the first point of contact for women navigating barriers to care. Long-term flexible funding allows them to move beyond crisis response and build durable systems of support that improve health outcomes at the community level. We have some wonderful such organizations here today, and we thank you for being here. We will be hearing from all of them shortly, but before that, let's go back to our girl Casilla here, and we will see how sustained investment means that prenatal care doesn't depend on whether her access to prenatal care does not depend on the fact that she can access health clinics. We see how community health workers now will conduct screenings across her community within her settlement. In Brazil, the Sisters of Notre Dame accompany communities to advocate for public policies that guarantee safe and dignified housing. They also work with ministries connected to their work who support outreach to people experiencing homelessness by providing food, clothing, and advocacy for stronger housing protections. Casilla's prenatal care becomes continuous instead of fragmented, and her living condition improves. For Rosa, it means that community-based legal advocates help her navigate land titling and secure joint ownership rights. With formal recognition, she gains protection from displacement and greater economic instability. Through the work of Green Hope Foundation, sustainable agriculture, and clean energy initiatives, we see how the environmental strain and daily labor burdens are lessened because of their interventions. Investment in these organizations make this access real for Rosa. Second, we must integrate housing, legal identity, and health policy. As we have seen today, when housing policy operates independently from public health and when legal systems function independently from social protection programs, women fall through the cracks. Coordinated governance, where ministries, local governments, and civil society collaborate, we see reduced gaps and we see more strengthened continuity of care. For Casilla, coordinated governance supported by organizations like Impulso Gov means previously excluded settlements are mapped, maternal health gaps are identified, resources are directed towards outreach in underserved neighborhoods. When she is counted, she can be served. For Rosa, integration means rural communities that were invisible in public data systems are formally recognized. Care deserts are recognized, and mobile clinics and telehealth becomes accessible. Women-led rural promoters conduct regular screenings within the village and identify cardiovascular risks early. This can help with coordinating transport when specialized services are required. Rosa's chest pain is addressed before it can escalate into a crisis, and geography stops becoming a determinant to her access of care. Third, we need stronger partnerships between universities, health professionals, and local organizations. Service learning programs, advocacy fellowships such as this one, and community-based research create reciprocal relationships, not extractive ones. These partnerships strengthen long-term impact while also training the next generation of health thinkers, health workers, health leaders to think structurally. Because when these partnerships are done well, they don't just produce reports, they produce resilience. We saw how Green Hope Foundation's environmental health initiatives reduce indoor air pollution and mold exposure, how sustainable agriculture and renewable energy programs reduce environmental strain and extensive labor work for women like Rosa, and how all these lead to fewer long-term health problems. We saw how the Sisters of Notre Dame accompany communities to advocate for safe housing and provide outreach to people experiencing homelessness. This is what it looks like when environmental stability, housing security, and health planning are treated as interconnected sectors and not just isolated sectors. And today it is my honor to introduce some of these organizations that are with us today. First, we have Sisters of Notre Dame. Thank you for being here. The Sisters of Notre Dame are a global congregation committed to education, social inclusion, and human dignity. Their ministries work with the communities experiencing poverty and social exclusion in Brazil, Peru, and United States. They advocate for safe housing, they support people experiencing homelessness, and accompany communities in addressing social challenges and strengthen local support systems. Green Hope Foundation is our second panel. We're going to hear from Green Hope Foundation soon. Green Hope Foundation is our another organization that's on the panel today. The Green Hope Foundation advances an integrated model of health, environmental stability, and social justice. Founded in 2012 and active across multiple regions, the organization operates from the principle that human and planetary well-being are inseparable. Thank you for being here. We appreciate your work. Next, we have Impulso Gov, another organization, which address exclusion from the bottom up. They operate at the critical intersection between data, governance, and equity. Impulso Gov works with municipalities and public institutions to identify populations that traditional systems fail to reach, including women who living in informal settlements, people without documentation, and those who move frequently due to displacement or economic instability. As we hear from our wonderful keynote organizations today, the question is not only what are they doing that works? We must also ask, what is it that other sectors must do to support, scale, and sustain these solutions? In conclusion, I want to reiterate that health is not a privilege, health is a right. And our right to health means more than access to treatment. It means the right to safe housing, the right to legal recognition, the right to protection from violence, to environmental safety, and the right to systems that recognize women as full rights-bearing citizens. If we're serious about health as a human right, then our policies must reflect that seriousness. That is the standard, and that is the work that we have ahead. Thank you.
Thank you. Thank you, Samara, for a powerful presentation. At this time, I would like to introduce our next speaker, Isabel Opice, the co-founder and chief operating officer of Impulso Gov, a Brazilian nonprofit organization that works in close partnership with federal, state, and municipal governments to strengthen public health systems and reduce health inequities. Isabel, welcome, and thank you for joining us.
Thank you, Margot. It's a pleasure to be here, and thank you, everyone. So I will share my screen to present you our work at Impulso Gov. Okay. So we are a non-profit organization based in Brazil, working at the intersection of data, technology, and public health. And we support local governments here in Brazil to strengthen the public health system, which we call SUS. And we do that by reaching those who need it most, by making those people who are invisible to the system visible. We are a non-partisan organization and a team of 60 people with different capabilities like data analysts, product managers, designers, and health specialists. And we work in close partnerships with local government in Brazil. And I want to be very clear with who we work with. We work with the poorest part of the Brazilian population in the cities where the only door to healthcare is the public health system. We have partnership with more than 400 municipalities in Brazil, and we support by our solutions 3.7 million people across the country. And what is the problem that we are trying to prevent? So we want to make the people that are invisible to the system to become visible. The main problem is that we have preventable suffering and death. And for instance, we have 67 maternal deaths per 100,000 live births, which is above the social development goal. And this number has been flat over the years in Brazil. And the reason why this happens is because of two main structural problems. The first is analytical problem. We have data, the data exists, but it's not organized in a way to find the people that need it the most. So the majority of primary care units in Brazil use electronic health record. So every time that a pregnant woman does a prenatal visit, it is registered, but if this woman doesn't come back in 2 or 3 months, no one will know. There's no flagging. And this is one of the problems that we are trying to solve. The second problem is training. So when a woman walks into a clinic, no one is asked to be trained the right question. There are no protocol to treat specifically the mental health issues that came up earlier. The system sees a headache, but it misses years of depression, for example. So those are the two main problems that we are trying to tackle with our solutions. And how is our approach? We don't replace the public health system. We work very closely with them to make them more effective. We work in four steps. So first, building on what exists, there's a huge number of professional health workers who work on the ground in Brazil, and also a very rich data infrastructure. And all our work is based on what already exists. We are not building parallel systems or putting more people on the ground. Second, analyze and monitor. So we help the health teams on the ground to make sense of their own data. And we also tracked our impacts to change if our solutions are not solving the problems. Third, we direct care to those who need it the most. So we try to figure out who are the people who didn't get an appointment on the last years or didn't get a screening or need mental health service, and those are the people that we focus focus the most. And lastly, we don't want to reinvent the wheel, so we are not creating new protocols or creating something very sophisticated. We ground our work on existing evidence and scientific protocols that are already being tested. So I will present our three solutions here. First, it's an actionable dashboard for primary care. Every community health worker in Brazil visits dozens of families, but they don't have a way to know who needed the most. And we organized the SUS data, the public health system data, for them to know who they have to visit, for them to organize their daily routines. So we create those dashboards like those, where they can see the name of the patients. Those are fake names and fake information. But for them, they can see specifically when was the person last visit, when is the deadline for their next visit. And by doing that, they can do house visitings for bring the people to the clinics. We work with chronic disease like hypertension and diabetes, and with women health on prenatal care and pap smear screening. Our second solution is sending automated WhatsApp messages, which are very spread across Brazil, directly to the patients. We send reminders of appointments, of screenings for them to come to the clinic. And we have been working with more than 100 municipalities with diabetes, hypertension, and cervical cancer screening. And this can be very effective. We ran an impact evaluation with Johns Hopkins University last year, and we saw a 4-time increase in women who received the text message in being examined. And this can change the game because if the pap smear test is done at the beginning of a cancer, it can catch us before it becomes fatal. So it's very effective in preventing suffering death in the future. Third, we talk a lot about mental health here and how it compounds on housing and gender violence. And what we see in our work, specifically in primary care, is that the professionals are not trained to screen and to treat patients with mental health issues that are not super severe. So we do have in Brazil very strong network of facilities for mental health issues like schizophrenia and bipolar disorder, but not for depression and anxieties, which are the main problems that we have nowadays. And what we do is to train professionals on the ground, so nurses, community health workers, social workers, to track patients on depressive symptoms and referral for severe cases if that's the case. But if they have just some symptoms that could be treated in primary care, we train them for conducting 4 sessions using um, uh, interpersonal therapy protocols for non-severe case. And this solves the problem that we don't have specialists like psychologists or psychiatrists for the entire population. So we train the professionals that we already have and using methodologies that have been proved to be effective. In one city that we work with, in the northeast of Brazil, the model has been adopted through a municipal ordinance, and now it's a permanent policy at the municipal level. So just to end, and I'll be glad to answer more questions in the end. What I would like to say is that women's health is not a sectorial issue, as we saw in Cassia and Rosa examples. They are related to many outcomes. So when you improve women's health, you improve child's health, family stability, education, economic participation, and that's very inspiring for me to continue the work that we do at Impulso Gov. Thank you. I'm very proud to be part of the conversation today, and I'm glad to answer more questions.
Thank you. Thank you, Isabel. Now, please join me in welcoming our last speaker, Kehkashan Basu, the founder and CEO of Green Hope Foundation, an organization that works at the grassroots in 28 nations to turn education for sustainable development into ground-level action by harnessing clean energy technology for social good. Kehkashan, we're pleased to have you with us.
Thank you so much, Margot, and hello, everyone. Really, really delighted to be here with all of you today to share this space with you. I always love being a part of the CSW events because they truly highlight the leadership of women and girls and all of our diversity. It shifts the narrative from women and girls as victims to women and girls as leaders, and rightfully so. And I'm just really honored to be here today to be able to share with you some of the work that Green Hope Foundation is doing. So, at Green Hope Foundation, as was already mentioned, we center women's voices in all of the actions that we undertake because we understand that there can be no sustainable development without women and girls at the core of any kind of decision making and any kind of implementation of solutions. And as of just a few days ago, we now work in 29 countries. So we are very happy about that because, for us, it's all about ensuring that we can meaningfully continue to create greater change in all parts of the world. So today I'll be focusing on the work that we do, particularly in Latin America, because we've seen how all of these issues of housing, health, environmental degradation, and equality, particularly for women and girls, how they're all deeply interconnected. And we've seen how housing conditions really shape environmental exposure, and then environmental conditions then in turn shape, the health outcomes. And when we see these systems fail, it's always the women and girls who carry the greatest burden. So we see the communities that we work with, we've seen them managing households, caring for children and elders, securing food and water, sustaining communities. And in the environments that they live in, the environment itself is often unsafe or unhealthy. But what I've learned and what my team has learned through this work is that these women that we're working with are the leaders of the solution. So just sharing some of the actions and the work that we do within Latin America. So my journey and Green Hope Foundation's journey in Latin America began in the favelas of Rio de Janeiro. And when I first started working there, it was literally in the first year of implementation of Green Hope Foundation back in 2012. And I started by spending time and speaking directly with the women and girls of the communities. So even at that age, as someone who'd been working as a child in the field, I knew that you could never come into a community with predetermined solutions. You always had to create something from the ground up. And that's exactly what our work here started as. So, I spoke with them about asking them about their daily realities, their housing conditions, health concerns, environmental challenges around them, and how these issues affected their families. And more importantly, when I'm speaking with them, one thing I asked was about the practices that they developed to cope and support their communities. And what I learned was that the women of the favelas are the architects of resilience. So I learned about, how they were organizing neighborhood efforts to keep their spaces clean, to look after their children, not only from their own families, but from the surrounding neighborhood households as well. And creating these informal support systems that allowed the communities to survive in difficult conditions. And so at Green Hope Foundation, it was really about supporting that and continuing to replicate that so that we were a catalyst of change for them. So through Green Hope Foundation, we then worked with the women and young people in these communities through education programs and environmental action initiatives, creating spaces where young girls, young women could learn about sustainability, about health, community leadership, best practices. And then these programs helped the young women to become active participants in improving their own communities, and also knowing when they saw injustice and fighting back against that. And what became really clear was that when we talk about housing inequality, we are also talking about women's health, safety, and dignity. So the lessons from Brazil really shaped how we approached our work in other parts of Latin America. So one of the countries we worked in was in Chile. So in several communities, we saw that environmental pollution and unmanaged waste contaminates not just the soil and water, attracting disease vectors and affecting air quality, but are also creating severe health risks for the women and girls. So we worked with the youth, the women, and the local community members to organize mass cleanups and restoration activities, mobilizing young people and young women to take ownership of their environments and really restoring public spaces, removing waste, and raising awareness about how the environmental injustice affects women's health. Because we saw that, as the women being responsible for the household environment and caring for family members, when they became sick as a result of environmental degradation, the whole family was affected. So when neighborhoods are polluted, the health burden on women also increases dramatically. So by creating these cleaner and safer spaces, we were able to reduce the hidden health risks that women face every single day. Another country that we work in is in Suriname on girls' care work and the right to health. So our work here revealed another dimension of inequality, the invisible burden of care economy that's placed on girls. So I remember like the first time I visited a school there in on the outskirts of Paramaribo, as I approached the classroom, I noticed a young girl standing outside the door. She was looking in through the classroom window with such absolute yearning in her eyes, and she was holding a baby. So when I asked the teacher why she was not inside with the other students, the teacher explained that because her parents had to work as the eldest daughter, she then became the caregiver for her younger sibling, even though she was only 7 years old. And so that moment really stayed with me because it showed how early gendered responsibilities can shape a girl's life. So while other children were in the classroom learning, she was already carrying the weight of caregiving. So through Green Hope Foundation, we began working with girls and young women in Suriname through nutrition education, health awareness programs, and food growing initiatives. So we taught girls how to grow their own food, understand nutrition, strengthening their health and well-being. And so these programs helped address food insecurity, but they also helped the girls to gain knowledge and confidence and giving them the tools to care for themselves and their communities. So, in doing so, we aim to reduce the pressures that are placed on girls and ensure that they have the opportunity to learn, grow, and shape their own futures. And finally, our work in Peru is centered on Indigenous women in urban and peri-urban communities. So, working on initiatives around farming and planting. So we have seen, that many of these women carry deep knowledge of sustainable agriculture and biodiversity that's been passed down through generations. However, as a result of mass urbanization and a pressure to grow cash crops, we've seen that a lot of the land that particularly Indigenous people and Indigenous women live on has become infertile as a result of growing crops that aren't native or indigenous. So, and we also saw that urbanization disconnects the communities from land, healthy food, and green spaces. So at Green Hope Foundation, we support the women in creating urban gardens and farming initiatives, so allowing them to cultivate indigenous crops and food in their own communities. So what these projects did was improved access to nutritious food, reduced dependence on expensive and often unhealthy food systems, and created greener and healthier environments in urban neighborhoods. So this was mostly on the outskirts of Lima. So for women, these community gardens and food spaces then became safe spaces for community leadership and resilience. So they were quite literally not just growing food, but like health, knowledge, and environmental stewardship within their communities. So that is all to say that, across Brazil, Chile, Suriname, and Peru, the lesson is very, very clear. Housing inequality, environmental degradation, food insecurity, all of these are not gender neutral challenges. They've never been gender neutral. They have always shaped women's health, women's time, and women's opportunities. But what we've also seen is that when women have the support system with the knowledge, resources, and opportunities to grow and thrive, they transform their communities. So when we talk about closing the gap in housing, health, and inequity, we must recognize the central role of women and girls in sustaining our communities. And so it requires investment in not just like infrastructure, but also in community leadership, in education, and in local solutions. Because we know that, when women are empowered to shape healthier environments and stronger communities, we do so much more than just addressing inequality. We quite literally create the foundation for healthier and more resilient societies for everyone. Thank you so much.
Thank you, Kehkashan. I would like to thank all our distinguished speakers for sharing their expertise with us today. As we move towards the conclusion of our session, it is my pleasure to invite Sister Anne Howard to offer the closing remarks and help summarize the key reflection from today's session. Sister Anne is an interfaith chaplain with the Sisters of Notre Dame de Namur and recently served as the director of campus ministry at Trinity, Washington until recently. Sister Anne, the floor is yours.
Thank you, Margot. Thank you, presenters, for this informative session. Special thanks to Professor Alan Peterbone and the Global Studies Department at Trinity, Washington University, and Ms. Drea Bergman of CGS, Citizens for Global Solutions, for shepherding the students. Thanks to Sister Isabelle Izika for facilitating the student fellows' access to the UN to experience the global wonder of relationships among nations being presented during the Commission on the Status of Women 70 this week. Trinity, founded by the Sisters of Notre Dame de Namur, Belgium, is located in Washington, D.C., where banners heralding Education for Justice line the rolling campus. Anastasia, Tomlinson, Belky, Lemus, Alvarado, and Samara, Husain, and others behind the scenes are reaching out to the Sisters of Notre Dame in mission in Lima, Peru, and in the Northeast region of Brazil to help put flesh on their research for this panel event. You may recall that in 2005, Sister Dorothy Stang was martyred because of her exposure of injustices around land ownership and land use in Amazon. Our sisters there continue to engage in intergenerational ministry in education and pastoral care. In addition to the Sisters in Mission, two broad-based organizations, vital organizations, have been invited to share their findings for our students regarding the gaps evident in Brazil and Peru. Isabel Opice from Impulso Gove and Kehkashan Basu of the Green Hope Foundation provide important data and enlighten us today with examples of how women's quest for sustainable development and quality health are being addressed in rural and in urban settings. Green Hope reminds us that human well-being and planetary well-being are inseparable. Through grassroots efforts, more vulnerable women are securing services that are rightfully theirs. Let us recall Anastasia's presentation, where a woman enduring overcrowded housing and a shortage of drinking water illustrates how multiple social challenges can create unsafe, unstable, and unsanitary conditions to make life unnecessarily difficult. Belky pointed out how topographical distinctions across Peru's Pacific coastal lands offer beauty to behold. Yet, near the capital city of Lima, people are vulnerable. Without proof of ownership of land, women are prone to experience legal problems as they plant and harvest food that nourishes their families. Lagging physical and mental health occurs as women seek ways to provide for their families and secure their rights of health care, maternal health, and education. The connection between the gaps and the stated outcomes set by the UN Sustainable Development Goals is operative. Samara offers this motto: health is justice in action. A graduating nursing major, she spells out how health and well-being can be understood as a collective of conditions that include safe housing, clean water, land control, legal support, familial stability, and power. Power, she says, is experienced when women can trust their service providers to disclose the experience of gender-based violence when necessary. Overall, we have seen how community-based interventions are aiming to improve the lives of women in Peru and Brazil. Working in solidarity with women most affected, and with the grace of the good God, may they have access to closing the gap to secure improved housing, health, and equity in Latin America. We hope these remarks from all our wonderful speakers have generated some questions. So I'll turn the program back to Margot, who will moderate.
Thank you. Thank you so much, Sister Anne, for the closing reflection. So I will open the floor for questions at this time. Our first question from our participant, I would like to open the floor to our panelists to answer or comment on. Can you further speak to the importance of culturally response interventions and including women leaders from within the communities in designing and delivering successful programs and services?
I can answer that, or I can try to. That was a very good question, because we often see that even with policies that are in place, unless there is a change in like attitude and culture, the change is not as effective. Which is why it is important that we start educating not only the children, not only their schoolgirls, not only the school boys, but we also need to start educating the leaders in the communities. Because a lot of the religious heads, for example, have a lot of influence in how women's health practices are dictated. They have a lot of influence in teaching and educating, which is why we need to make sure that the frameworks that we design, the solutions that we come up with, are culturally appropriate and they connect with people so that people feel they have a lot more trust in the system that support them, basically. So it will start with no matter how many policies that we talk about, we do need to work on making it culturally appropriate. I hope I answered that question.
I can comment on that also. So one of our solutions, as I showed you, is sending WhatsApp message to people for them to go to exam, a screening, visit a doctor. And the results that I showed about the pap smear, before designing the solution, we did a lot of interviews with the professional health teams and also with women. And we met what are the constraints for women doing a pap smear. And one, for example, is the women are afraid of getting to the clinic and being examined by a man, a professional worker that is a man. And so one way to address that is to send in the message, in the text message, that they will be examined by a woman. And this is a very small example of including the people in the design of the solution, understanding more deeply what are the concerns, what are the real barriers for people to doing an exam or to visiting a clinic. And by doing that, I'm sure we can be much more effective.
Thank you so much. Thank you so much for your comments. For the second question from our participants, I would like to open up to Isabel and Kehkashan to answer or comment on. Grassroots movements across Latin America have been instrumental in advancing women's access to justice and social protections. What strategies have been most successful in translating community-led advocacy in sustainable institutional or legal change that can scale beyond local communities? Okay, Keshawn, you can start us off.
Sure. Yeah, I mean, that's a really great question because, yeah, there's anywhere in the world, including in the communities we work in Latin America, that there's a very big gap between what goes on at the legal or the highest levels of policy making and what grows on at the ground level. For us, it's more about working with like local municipalities and kind of upscaling that. So it's not just community led, but the first step is towards like, the legal process or working with governmental organizations is starting with the local municipalities, then kind of moving up from there. And it's been kind of a long process for us because again, it's not the easiest to do, and very often as NGOs, we are the ones kind of going in there and working in the communities, and it's kind of disconnected from like the policy space. But yeah, that is kind of how we work with stakeholders that aren't just like the community or the nonprofits. But yeah, it's definitely a really long process. The first step for us is definitely local government and kind of going from there.
Yeah, it's kind of similar for us. I think something common to Latin America is that we have big governments, and usually the government reach the people, but there's a lot of work to be done for the government to become more efficient. And I see the government as the main path to scale the works of community-led work. In our case, we also partner with local governments, but we also have a partnership with the Ministry of Health because we have a large scale. We work with 400 municipalities, but there are 5,000 municipalities in Brazil. So the way we see to scale our work at a national scale is not reaching every municipality, but trying to scale through the federal government for instance, the mental health project to become a protocol of the Ministry of Health, or for the technology solutions that we make to be spread across the entire country.
Thank you so much. Thank you so much for answering that question. For the third question from our participant, I would like to open up to Isabel to answer or comment on. In many regions today, housing insecurity, health disparities, and discriminatory legal frameworks often intersect and reinforce each other. Based on lessons learned from organizations working on the ground in Peru and Brazil, which policy reforms or governance models have been most effective in addressing these issues comprehensively rather than isolated sectors?
Yeah, that's a very good and also difficult questions. The government works sector by sector. So when we talk about intersectional policies, it demands a lot of work and articulating a lot. I think, like, as we are talking now about empowering women, I think that's one example, as I said in my conclusion, that if we solve the specific problems, for instance, in women's health, we talk about prenatal care, but one that's very clear is, and you've talked about in your presentation, is reproduction planning. And if we work on that, we know that there is effect across very different sectors. So I think one way of addressing those issues in housing, in health, is trying to leverage the policies that have a huge impact on other policies like women's health, and try to get more resource by showing the potential impact that it can have.
Thank you so much. Thank you so much, Isabel. We have a comment from one of our participants, which says, I believe that focusing exclusively on women can unintentionally alienate men and create tension between the sexes. A more effective approach is one that includes everyone. Policy that targets investment towards specific groups can also be controversial, as some people view them as discriminatory rather than inclusive. Emphasizing equal opportunities and broad community support may help avoid division while still addressing the underlying issues. Does anyone on the panel would like to offer their perspective from our participant?
Yeah.
Yes.
I would just very quickly like to add that, yeah, that's absolutely a valid point. But when we think about, oh, okay, if you're just focusing on one another group might feel discriminated against, we have to understand that the playing field is not equal. It's not even equitable. So when we say that, we're focusing on women and girls and we need policies and solutions that focus on uplifting women and girls, it's because it's like everything else is kind of here right at the top, and then women and girls, and the focus on them is kind of right here at the bottom. So if you say, oh yeah, we need a policy or solution that's all equal, it's like, okay, only the people who are kind of up here are impacted positively, but the people who are here still cannot access that. So it's more a question of then about equity instead of equality. So we are working to put solutions and policies into place that make the playing field equitable for all, because historically the injustices have impacted the women and girls the most. So in order to make sure that we create an equal playing field, that's the ideal state for everyone, we have to first focus on equity. And that means addressing the particular needs and wants of women and girls. And the benefit of that is that when we address the needs and wants of women and girls, every single person of any gender, of any age, they also benefit, because women and girls are at the core of any kind of community development. So that's always been, like, when we see in our work as well, the emphasis on equity first, and that in turn creates equality for all. So yeah, I hope that answers that question or comment.
Yeah, I can add to that. Specifically in health, it's super important to target. You have to target to be more effective. And on women's health, that's true that that it's different, right? There are specific issues, prenatal care, pap smears that are targeted to women. One way to include men into the discussion is, for instance, in prenatal care, we've seen that it makes a lot of difference in maternal health and maternal and child health if you have a partner with the woman during the prenatal visits. And this is also a way that you can bring more men to the clinics, because this is also the group who lacks appointments and treatments of hypertension and diabetes, that it's a huge cause of death in the future. So it's super integrated. We have to analyze it different because we are talking about different issues. And when you work to improve women's health, you might also improve men's health by bringing them to the clinic.
Just to add on to that too, kind of circling back to the question I had about the culture responsive, I think the only place where, not the only place, I think when we're talking about policy, I think men can involve, the way we can involve men is by educating them culturally. I noticed in the comments that you said that the gentleman said that he wanted, I'm sorry, I'm fumbling a little bit, but I think you mentioned in the comments how The benefits would be compounded if we have more males in the conversation, which is true, because you're right. We need to appeal to the men who are in leadership positions, which outnumber the women in leadership positions. But the only way we can do that is if we see a cultural shift to influence them. And we can start that in the schools by educating our boys, educating the boys about how gender equality works, educating them, giving them more comprehensive sex education. Those are ways that we can involve men. But at the same time, like Kehkashan mentioned, it's about equity. We're talking about equity. Girls are not the same position that men are, unfortunately, now. But just to add on to that one. Thank you.
Thank you. Thank you so much for adding on into the question. For our last question, I would like to open up to Anastasia, Belky, and Samara to answer. What role should universities, health professionals, and data-driven organizations play in transforming structural determinants of health into actionable policy change? Anastasia, you can start us off.
I'm sorry, may you please repeat the question, just so I understand?
For sure.
Mhm.
What role should universities, health professionals, and data-driven organizations play in transforming structural determinants of health into actionable policy change?
I believe that actionable policy change does start with the youth. And so just empowering us to be able to start having these conversations in the school and working with the school nurses, with the school administration to figure out what the issues that we have are before bringing it to actual policy, if that makes sense.
I can go next. Um, well, here at Trinity, we do have like research programs, and a lot of institutions around America also contribute to research. So I think it's important to take those, um, you know, that data and pass it along to policymakers so that they can incorporate that into any policies that they're creating.
I agree with Anna and Belky. I think they did a wonderful job explaining it. I think if you kind of combine the both, like Anna said, the youth advocacy, because we've seen how all across the world, especially now, how when the youth speak up, changes do occur. Like we have power to make changes. So if we're not advocating, if the youth is not involved in community work, if we're not going to our local community and saying that, hey, this is a problem and I want to change it. Let me advocate, let me talk to my leaders in my community. Let create a dialogue. Unless we do all that, then I we won't see any changes. But we should start with the youth. But I know that this is another thing that we don't talk about too often, but we should also look at our elders and maybe try to get them to change. I know we're hesitant because we say they're set in their ways and won't change, but I think it's a conversation worth having, and it's definitely an effort worth forwarding. Warren.
Thank you so much. Thank you so much. I will also ask Isabel and Kehkashan to comment before we wrap up.
Yeah, I actually love the aspect of intergenerational solidarity that was just brought in. I think that there's like every single generation brings something to the table. And, I mean, as feminists, we can see that, we are building on the work that feminists of past generations have built for us. So I think that is really, really wonderful. And I think that getting the wisdom of all generations of people from really everywhere, regardless of age, or really taking into account age, gender, race, and seeing all of the lived experiences, bringing all of those experiences together can help create meaningful change. So yeah, I'll end with that.
Yeah, that's very inspiring. And yeah, I think a lot of what we've talked about is how to strengthen woman-led work. And we've seen a lot of advancing the last few years, but it's not a linear path. So being in forums like this where we can discuss, where we can learn about other experience and exchange, it's really helpful and really inspiring for us to continue our work, and very thankful for being here.
Thank you so much. If there are no further questions or comments, we'll begin to conclude our session. I would like to sincerely thank our distinguished speakers for their valuable insights and contribution to today's session and discussion. I would also like to thank all participants for joining us and for your engagement throughout this event. Today's conversation has highlighted important perspectives and reinforced the value of continued dialogue and collaboration on this issue. With that, I thank you all once again for your participation and wish you a wonderful day. Thank you.